Welcome to this training video provided by Optometric Billing Solutions for staff members at our offices as we prepare for the changes coming with ICD-10. As we know, the deadline is just around the corner. On October 1st, the entire healthcare industry in this country will switch to the new system. Now, it's important to note before we get started that while our doctors are always responsible for the coding for their patients, as staff members, we can play a very large and important role to help ensure that this transition goes smoothly. To get started, a little bit of history on the International Classification of Disease Codes would be appropriate. These are compiled and maintained by the World Health Organization, which is the public health branch of the United Nations. Now, these are worldwide diagnosis codes designed for use more than just here in the U.S. Disease classification goes back more than 100 years. In fact, the first international classification was published in 1893 to track cause of death. But as our knowledge in medical sciences and diseases expanded, so did the codification system, and over the last century, we've seen many revisions. Our current code set, ICD-9, has been around for a very long time. It was adopted in 1978, so here at the office we laugh and say it's as old as Brooke and Branda, so it's time for a change. ICD-10 was actually completed in 1992, and the rest of the world transferred over to the new system very quickly, partly because of its updated terminology and its capacity for new codes, as well as its more detailed diagnoses. So you can see the U.S. is pretty late coming to this party. Now, an important point to get started. On October 1st, only the diagnosis codes will change, not our CPT procedural codes. We will still be billing out those procedure codes that tell insurances what services we are providing for office visits, testing, and hardware such as glasses and contacts. And we'll still be using most of the same modifiers since these are part of the procedural system. Only our diagnosis codes will change. Let's get started with a simple comparison. For this, I've chosen a common diagnosis for dry eye. In ICD-9, it was 375.15, but in ICD-10, it will be H04.123. Now, it's pretty easy to see some differences in looking at these two numbers. ICD-9 codes were all numbers, where ICD-10 are a combination of letters and numbers. And in fact, all ICD-10 codes begin with a letter. ICD-9 was 3 to 5 characters in length, where ICD-10 codes will be 3 to 7. And ICD-9 maxed out at about a capacity for 13,000 diagnosis codes, where ICD-10 can handle up to 160,000 codes, so it can accommodate 12 times more diagnoses than our current system. The biggest change that we are going to see with ICD-10 codes are specificity and detail. Details, details, details. Now, the good news in optometry is that the diagnosis codes we will use are fairly simple and straightforward compared to other specialties. I would not want to be an emergency room doctor right now because those diagnoses attached to accidents and injuries are very demanding, but probably the worst is orthopedics. Their specialty had a larger growth in codes that they have to handle and accommodate for than I think any other specialty out there. So optometry, once we learn the system and understand it, it really is going to be fairly easy. Okay, as staff members at an optometric practice, what do we really need to know? Well, if we learn these three things, we will be much more prepared for the changes that are coming on October the 1st. First of all, we need to understand the organizational pattern of the ICD-10 codes. Right now, when we see a new code, they look strange. They look foreign. In fact, if we're honest, they look intimidating. But the more we understand how they're organized, the more familiar they will look and the more comfortable we will become. And because we're an optometric practice, we need to learn all of the new routine vision codes. There are more of them, but they're pretty simple. And finally, we need to know 8 to 10 categories of the most common medical diagnoses that our office uses, like cataracts, dry eyes, glaucoma, and conjunctivitis. Okay, let's get started. Let's look at how ICD-10 codes are organized. As we said, they can be up to 7 characters long, but really most of our optometric codes will be 5 to 6 digits in length. All ICD-10 codes begin with 3 characters before the decimal. This is called a category, and it is here that conditions are organized by body system, disease type, or symptoms group. In optometry, the categories will always start with a letter and be followed by 2 numbers. Now, we will live in the world of H00 to H59 since this is the category for diseases of the eye, but we will frequently see diseases from other categories related to vision, like diabetic retinopathy, which is E10 to E11, depending if we're talking type 1 or type 2, and we'll see injury codes for corneal abrasions or foreign bodies. But it is here in these first 3 digits that we can look at conditions and say, oh, this is a diagnosis for glaucoma, or this is a diagnosis for conjunctivitis. It is the digits after the decimal that give us the most specific information about these codes. In optometry, the first digits following the decimal will give us the etiology as well as the location of the condition. Let's talk about these. Etiology is a fancy word that means cause. So if the category is conjunctivitis, this will be followed after the decimal by 1 to 2 characters that will tell us the cause of the conjunctivitis. For example, chronic allergic conjunctivitis. Following the causal digits will be a single digit that will give us location. And because we live in the world of optometry, this will generally be which eye, although sometimes it will be which lid. This is the laterality digit that will tell us right, left, or both eyes. Now, before going on, I need to point out something that caused me some trouble in trying to understand these ICD-10 codes because I was trying to define what went in a specific position. I was trying to say, okay, the fourth position is for the causal digit, then the fifth position is for the location, until I realized it is not the position, but the order of the digits that count. So, if the diagnosis has just a single character to denote cause, then that causal digit will be in the fourth position and it will be followed by the location or the laterality digit in the fifth position. However, for those codes that require 2 characters to denote cause, then those cause digits will be in positions 4 and 5, followed by the location or laterality digit in position 6. Finally, let's talk about the 7th character. This is called the extension and it is unique to ICD-10. There was nothing like it in ICD-9. Not all ICD-10 codes have 7 digits. In fact, there are entire chapters in the coding manual that do not have diagnoses with this 7th digit extension. The 7th digit extension is reserved for specific codes that require additional information not needed on other codes, and it is here that we place it. In optometry, there are 2 situations that we will be using this 7th digit extension, and that's glaucoma and injury. Glaucoma codes require that the doctor report what stage the diagnosis has progressed to, and injury codes require that we report what physician encounter. Is this the first encounter or follow up subsequent encounters? And we will talk about this later. Okay, that's how our ICD-10 codes are organized, and I hope this information will help you become more comfortable with these codes and understand them better as we move forward. I think it's time to actually look at some diagnoses. Let's start with something simple, our routine codes. Our routine codes for refractive errors all begin with H52. This is probably the most important slide we will look at today, and so if you remember nothing else, I would ask that you remember this number. Just like in ICD-9, we knew that most of our routine codes began 367, so they were very easy to identify. The same holds true in ICD-10. Anytime we see a diagnosis that begins H52, we know that this is a diagnosis for a refractive error that will be routine in nature, and it's important that we remember this number. Why? Well, if you're the cashier, the checkout person, and a patient comes forward with an exam pointed to age 52, then that tells us this is a routine exam and this needs to be allocated to the patient's routine payer, like VSP or IMED, or their medical payer in those cases where there's a routine benefit. Likewise, if you're the optician, we know that all hardware short of medically necessary contacts or glasses after cataract surgery need to be pointed to an H52 diagnosis. Okay, let's look at these codes further. After the category of H52 for refractive error, we will need 1 to 2 additional digits to identify the cause of the refractive error. And here I really appreciate ICD10 because there's such a strong correlation between the ICD9 and the ICD10 codes for routine diagnoses that it will make them very easy for us to remember. In ICD-10, the diagnosis for hyperopia or farsightedness was 367.0. In ICD-10, that becomes H52.0. Likewise, myopia was 367.1, and in ICD-10, that remains H52.1. Now, there is a little bit of difference with astigmatism, and we'll talk more about this later. But for now, let's say that for regular astigmatism, in ICD-9, that code was 367.21. In ICD-10, that now is H52.22. But presbyopia used to be 367.4, and in ICD-10, it's H52.4. But we are not done. Remember, we said that specificity, additional information, was the byword for ICD-10, and this remains true even for our routine diagnosis codes. We need an additional digit to tell us which eye. Because we're dealing with two eyes, we can expect a laterality code for most of our diagnoses that tell us left, right, or both, bilateral. Now, in ICD-10, the right eye is usually indicated with the numeral 1, the left eye with 2, and bilateral with 3. Now, before going further, we should take a moment to discuss unspecified codes. The digits 0 and 9 in the new manual are often assigned to unspecified, but these should be used with extreme caution. From the very beginning, when we first started hearing about ICD-10, we were told that unspecified codes were not acceptable. And there was even some discussion that some payers would not process these codes or that they might process them at a lower rate. So until we have some resolution on this matter, for today's discussion, let's just end by saying that we should see unspecified codes coming from our doctors very rarely, but that instead we should always see 1 for right, 2 for left, or 3 for bilateral. Let's look at these laterality codes in conjunction with the diagnosis, hyperopia. As we said, H52 is the category, which means refractive error. 0 means the cause of the refractive error is hyperopia, and the 1 following means hyperopia in the right eye only. H52.02 in the left eye, and H52.03 bilateral in both eyes. Okay, let's talk about myopia. Now you may have noticed that for the purpose of this training video, the digit that denotes cause I've colored in blue, but the digit for laterality I've covered in red. So for myopia, H52, refractive error, the category, 1, myopia being the cause, 1, meaning in the right eye. H52.12, myopia in the left eye only, and H52.13, myopia in both eyes. Now, the laterality digit of 3 will be the one we will see most often since most people are either myopic or hyperopic in both eyes. Let's discuss astigmatism. Like ICD-9, astigmatism is 1 digit longer than the other refractive diagnoses to denote regular or irregular, but here we have some differences. In ICD-10, the digits have been flipped. In 9, regular astigmatism was 367.21, where in 10 it's H52.22, whereas irregular astigmatism was 367.22. In ICD-10, it's now H52.21. So we'll have to remember this difference. So looking at our complete diagnoses codes for astigmatism, in the right eye, H52.221, left eye H52.222, and both eyes H52.223. Presbyopia is H52.4, and we are done. Presbyopia is the only routine code that is complete with only 4 digits. It does not require an additional character to designate which eye. In fact, H52.4 for presbyopia is one of only a handful of diagnosis codes in ICD-10 for optometry that is complete with being only 4 digits in length. We had a doctor call last week and ask if there was going to be a comparable code in ICD-10 for V72.0. You'll remember this is the code that we use when we see those rare patients without any refractive error. In ICD-10, the V codes have become Z codes. This is the category for miscellaneous health factors not related to an eye disease or illness, and so for those rare patients with perfectly shaped eyeballs that have no refractive error, then the code that we can use in ICD-10 is Z01.00, which is defined as encounter for examination of eyes and vision without abnormal findings. Now there is another code we should discuss briefly, Z01.01, which is defined as encounter for examination of eyes and vision with abnormal findings. And at first this code confused me because I felt if the doctor found something, why wouldn't he or she be coding that? Until someone pointed out this would be used for those emetropic patients coming in for a routine exam, presenting with no symptoms, no complaints, but during the course of the examination, if the doctor did find something abnormal, that exam would still have to remain routine since that was the patient's original intent. So this would be a case where the doctor could code Z01.01. Before proceeding further, it is important to point out that these Z codes should only be used when there's nothing else to code for those patients with no refractive error. Since most people have some measure of refractive errors, then we should not see these Z codes very often. So, let's talk about the rules. Our routine filing rules still apply. Nothing has changed except the way our diagnoses look. If we see an H52 diagnosis in the first primary position, then the claim is deemed routine in nature and should be filed to either the patient's routine payer like VSP or IMED or Davis, or to their medical insurance if it has a routine benefit. Likewise, all hardware except glasses after cataract surgery or medically necessary contacts should be pointed to an H52 diagnosis. Guys, that's the routine codes. I think we've got it. Let's talk about the medical. Anything that does not start H52 or Z01 is a medical diagnosis, and we could probably stop there. However, it would probably benefit us to learn some of the more common categories for the medical diagnoses we see most often, like cataract, conjunctivitis, dry eye, and glaucoma. So let's talk about these. My purpose of this section of this video is not to have you learn the specific medical diagnosis, but to expose us to a larger breadth so we will start to feel more comfortable and recognize them more easily. Let's start with cataracts. You'll remember that in ICD-9, this category was 366. In ICD-10, the category for cataracts is H25. And just like in our routine diagnoses, we should expect to see that category followed by either 1 or 2 digits to denote the cause of the cataract and a final digit to denote laterality. I've given 2 examples here to help show us the different links we can expect to see with these medical diagnosis codes. A nuclear cataract is denoted by the single causal digit of 1. So H25, the category for cataract, 0.1 nuclear 1 means in the right eye only. H25.12 nuclear cataract left eye, and H25.13 nuclear cataracts both eyes. So nuclear cataracts are complete, being 5 digits in length. However, cortical cataracts require 6 digits because the cortical cataract causal diagnoses are 2 digits in length. So H25.011 cortical cataract right eye, H25.012 left eye, and H25.013 cortical cataracts in both eyes. Let's look at conjunctivitis. In ICD-9, this category was 372. In ICD-10, it's H10. Like cataracts, we should see 1 to 2 digits following the decimal to identify the cause of the conjunctivitis, followed by a final digit to denote laterality or which eye. I give an example here for acute viral conjunctivitis, which is denoted by the causal digits 0, 1. So H10 category for conjunctivitis caused by zero point 0.01 acute viral, 1 in the right eye only, H10.012 left eye only, and H10.013 acute viral conjunctivitis in both eyes. So we're starting to pick up this pattern that most of our optometric codes will have 1 to 2 digits showing cause and be followed and end with a laterality digit of 1, 2, or 3. But there are exceptions. Why I point it out is here under conjunctivitis, one of our most common conjunctivitis codes, chronic allergic conjunctivitis, requires no laterality digit. So H10.45 is a complete code. It does not require the additional digit. Disorders of the retina. There were probably more changes in this category than some of the others. You'll remember they were all lumped together in ICD-9 with a category of 362, but in ICD-10 these have been broken out into H33, H34, H35, and E10 and E11 for diabetic retinopathy. In fact, we saw some very large changes with diabetic ret that let's talk about now. And in the course of talking about diabetic retinopathy, I also want to discuss how we cannot correlate one code in ICD-9 equals one code in ICD-10 because generally we do not have a one-to-one correlation between the two code sets. Sometimes we have more diagnoses in ICD-10, as we've seen so often. The example here, our routine vision code for myopia 367.1, there was only one diagnosis code in 9, but we have 3 in ICD-10, and if we count the unspecified, we actually have 4. However, sometimes we have fewer diagnosis codes in ICD-10, as in the case of diabetic ret. Diabetic ret has been moved into the category with diabetes, and we no longer have to code diabetes in the primary position, followed by the manifestation of the diabetic ret in a secondary position, but one code now does it all. Last year, if we had a patient come in that had diabetes, diabetic ret with macular edema, the doctor had to code 250.50, 362.05, and 362.07. This year, all the doctor has to code is E11.331, and the doctor is done. Diabetes with diabetic retinopathy and macular edema. Now, let's talk about conversion websites. We've seen these for about a year. They're called GEM mapping, general equivalency mapping. And as we start ICD-10, there's going to be a very strong temptation to go out to the internet to one of these websites where you can plug in the ICD-9 code and it's supposed to give you the equivalent code in ICD-10. But while these are useful, they are not reliable because we do not have a one-to-one ratio between the number of codes. So while these can get you in the ballpark, these websites cannot convert an ICD-9 code into an ICD-10 code reliably. Okay, let's talk about glaucoma. Glaucoma in ICD-10 begins with an H40 category, and it is one of the more challenging diagnoses because there are different coding requirements in ICD-10 for glaucoma. Glaucoma is one of only 2 instances where in optometry we will be using that 7th digit extension code. Now, it's not required on all glaucoma diagnoses. For example, suspect glaucoma does not need the 7th digit, but most of our confirmed glaucoma diagnoses require that the doctor code the stage that the disease has progressed to. Yeah, there's a code for unspecified, but we really don't want to use that. But the doctor will be coding mild, moderate, severe, or indeterminate. Let's look at some examples where we use this 7th digit extension in glaucoma staging. I've given two examples here. The first is open angle low tension. The H40 is the category that says glaucoma. Open angle low tension has a two-digit causal designation, 1, 2, and the 3 indicates laterality, in this case, both eyes. So it is then in this seventh position where the doctor will code the stage of the glaucoma. Unspecified, but mild, moderate, severe, or indeterminate. Now, this is a pretty good example, but I want to show you another one because there's something unusual. Primary open angle glaucoma does not require laterality. It does not require a laterality digit. Therefore, H40 for glaucoma, 0.11 meaning open angle primary, but because there's no laterality, we have nothing in the sixth position. Therefore, we have to use an X as a placeholder so that when the doctor codes the stage for the primary open angle, it will remain in the seventh position. Now, as an important reminder, not all glaucoma codes require that seventh digit extension. So when we're unsure, we're just going to have to look it up. Optometric Billing Solution has compiled what we feel will be a very useful quick reference guide for you that you can use for this purpose, and we will discuss that at the end of this video. For right now, let's talk about the other instance where we'll be seeing the seventh place extensions, and that's for injury codes. Injury codes require a character in that seventh extension spot in order to document the physician encounter. And by this I mean A for initial, meaning the first exam for this injury. We're not talking about a new patient, the first time we see the patient, but the first time we see the patient in relation to this injury. D means a subsequent encounter or a follow-up exam for the injury, and S means sequela. This means a late effect from a previous injury. No time frame involved, but sometime in the past, the patient was injured, and we are now seeing the patient because that past injury is giving them complications. A good example of our injury codes that require the seventh digit extension will be foreign body. T15 is the category, and corneal foreign body is denoted by the point 0. 1 and 2 means right eye or left eye. Again, we only have 5 digits without the seventh digit extension. There's nothing in the sixth spot, so we have to use the placeholder. So when the doctor codes what physician encounter this visit is, it can remain in that seventh position. Likewise, we see the same thing with corneal abrasions. The category for abrasions is S05. The 0 indicates of the cornea, 1 right, 2 left. But we have nothing in that sixth position, so we have to use the X as the placeholder. So when the doctor codes the physician encounter, it can remain in the seventh extension spot. To wrap up, let's talk about just a couple of other useful codes, the Z codes. As we mentioned before, the Z codes are used to indicate we're seeing the patient for a reason other than an illness or disease, but we're monitoring them for another condition. A very common code is pseudophakia, where the patient has had cataract surgery and has an intraocular implant. The code in ICD-9 was V43.1. In ICD-10, this code is Z96.1. And it's important to point out that this is a complete code. It's one of the few codes in optometry that is complete, being only 4 characters in length. Another common code we expect to see are for patients taking high-risk medication. This can be Z79.899. And as an important addenda, we should say that anytime we see these Z codes, except for Z01, these are considered medical in nature and should be reported to the patient's medical insurance. Let's start to wrap up today's training with a discussion of code length. The transition into ICD-10 may very well be one of the most challenging changes our doctors will face in their entire careers. But we as their staff can help serve as their safety net to make sure these codes look valid as we face these unique challenges of ICD-10 together. In optometry, most of our codes will be 5 to 6 characters in length. We have seen 2 3-digit codes so far. There may very well be more, but we know that I-10 for high blood pressure, which is one of our incentive diagnoses for VSP, and R51 for headache, not otherwise specified, are both valid codes and they're only 3 digits in length. We've already discussed 4-digit codes that we've seen are presbyopia and pseudophakia, also E78.0 for high cholesterol, another incentive diagnosis for VSP. And today we've talked about the 2 groups that require 7 digits in some of our glaucoma and our injury codes. But generally moving forward, we can expect 5 to 6 characters for our codes. So why is this important? If you're a tech, you can see your doctor's exam and you can see his codes. If you're the checkout person, you will be reviewing his coding. And if in the process you see a code that just doesn't look right, it's 4 characters, it's not presbyopia, it's not pseudophakia, and it appears to you that it perhaps should be longer, or you see a code that doesn't end in a laterality digit of 1, 2, or 3, and you know that most of our codes do. These are situations where you can stop and say, you know what, I want to review this for my doctor just to make sure it's a valid code that will process. In order to assist you, Optometric Billing Solutions has put together a quick reference guide. We have compiled some of the most common codes in optometry and listed them by diagnosis name and the ICD-9 and comparable ICD-10 equivalents. We'll send this to you. You can print it out. It's 22 pages long, but this document is most effectively used as a PDF that you can download to your desktop because it's searchable. You can use Control F to search by the name, by the description, or by the code itself to see, is this a valid code? Is it long enough? Do I have the right digits? There is no question that the next few months are going to be stressful and we have some challenges ahead. Just know we all handle difficult changes in different ways. We pray, we freak, we procrastinate, we eat, and we pout. But gradually it starts to come together, and what was hard becomes easier. In the end, all we have to do is pull together. Please know that Optometric Billing Solutions is here to help. Do not hesitate to call us if you have any questions. Thank you for your attention today and good luck.